in healthcare in the United States today, employer-based health insurance is like vegetables. There's a lot of it around. Very, very few people really like it, but it's sort of hard to imagine living without it. And in fact, if we want our health system to get bigger and stronger and healthier, we probably need more of it rather than less of it. All of us, well, I can't speak for those of you in the audience, some of us, Easterners, would rather have a cheeseburger or some ice cream or some cake or whatever one's particular taste might be, or even, since we're close to California, fruits of various kinds. But in fact, in the health system as it's now configured in the United States, it's very hard to figure out how we would improve things without greater reliance on private health insurance, even though we're increasingly conscious of its shortcomings, and even though nobody really loves it, they just sort of accept it. There are some very powerful advantages to employer-based health insurance. Obviously, it provides a mechanism for flexibly allocating financial responsibility between the individual and the individual household and the employer. I think the most important thing as we look about how the system is evolving and the kinds of changes that are talking about is that in any large employment group, and the majority of folks with employer-based health insurance are in relatively large groups just because that's the way the arithmetic works. You get a very substantial pooling of risk. You get very substantial internal cross-subsidization of relatively healthy workers in any given year, in effect subsidizing relatively less healthy workers in any given year. You have enough ability to influence the market so that insurers or self-insured plans cannot engage very effectively in risk selection behavior of one sort or another in a way that is very, very hard to sustain in any substantially more fragmented or a decentralized system, something we'll get back to in a little while. There's an enormous set of economies of scale just in the management and administration of insurance products from selling and administering large groups as opposed to individual or even small group contracts. And it does create, in fact, in many communities in which the insurers and or providers are relatively concentrated in a few systems or a few hospital organizations or things of that sort, it does create some amount of purchasing power or negotiating power on behalf of the buyers that is almost impossible to envision existing in a much more fragmented or decentralized way. While the impact of large purchasers, large private sector purchasers on the actual performance of healthcare markets in most of the country has probably been exaggerated over the last number of years for a variety of reasons. It's certainly not negligible, and in some parts of the market, in some parts of the country, it's very powerful and it's very influential. If, in fact, the healthcare system is trending on the delivery side inevitably towards the direction of greater concentration and more what the economists would call oligopsony on the part of sellers of health services in a way that becomes almost impossible to prevent, then having some degree of cartel-like behavior on the part of the purchasers may be the only way to sort of level out the dynamics of the marketplace. And one illustration of that is the way that some of the employer groups have actually made some progress in requiring the provider community to undertake quality improvement measures or develop quality standards that wouldn't have happened otherwise. The other most important thing, I think, in terms of our options for the future and in terms of thinking about policies and politics in access to health care is that the American population, particularly the 60% of the population or so that is connected to the employer-based health care system, tends to be very satisfied with it and tends to think reasonably well of it. There are some real problems, and you'll hear a lot more about them today, with employer-sponsored health insurance. Again, to me, the major problem with it is that for many folks who are employed, health insurance doesn't come with it. And the labor market, if anything, in the United States over the last decade or so has probably gotten more unstable and more volatile than it used to be in the past. You've all read the stories or heard the cliches about how in the 50s or earlier it was not uncommon for somebody to go to work for a large corporation in their 20s and stay there until retirement, and how that is increasingly the anomalous pattern, not the other way around. It's sort of hard to get a reliable feel for just to what extent the rate of job switching has actually increased over recent years. But certainly there's a growing perception that it's more and more common, and to the extent that health insurance is connected to employment, then as employment becomes more volatile and more unstable, people's insurance becomes more volatile and more unstable, and there's the risk that healthcare arrangements associated with insurance become more unstable as well. There's also a major tilt in the private health insurance market, which is to say that it really works, I think, relatively well for large firms and the majority of folks who are employed in large firms, and less well all the time for small employers. They are the least likely to offer insurance at all. They are the most likely to require a relatively substantial employee contribution to that insurance. And for a whole variety of reasons, they pay substantially more for their health insurance than folks in large firms. It continues to be the modal norm of provision of health insurance for the majority of American families. Most of the people who like it, who are in it, like it and think very well of it. People understand reasonably well the advantages of being connected to a large purchaser as opposed to being an individual in the marketplace. Some of those advantages are quite tangible and quite measurable. But there are big holes in this system, and there are a growing proportion of all people who are employed or connected to the employment market who don't have health insurance or can't afford it, who aren't getting it through the system, and those folks are disproportionately employees of smaller firms and people of lower income. Now, the other thing that sort of keeps the employment-based health insurance system alive, that permits it to function at all, are the government programs, most notably Medicare and Medicaid. And if we could have the next slide, which at the moment cover something on the order of 20 to 25% of all Americans and all American households. And because they exist for the purpose of covering the most expensive and most likely to be ill parts of the population, account for just over 40% of total health care expenses. But what Medicare and Medicaid do, almost by definition, by coverage of the elderly and disabled and by the operation of Medicaid spend down in many states, is take the highest risk folks out of the private health insurance market, thus making it possible to operate a private health insurance market at price levels that people thought were historically affordable. On a number of criteria, if we could have the next slide, the performance measures when applied to the public health insurance programs are pretty good, although of course the programs are dramatically different one from another. Certainly if one is primarily concerned with administrative costs or overhead, you can't beat large public health insurance programs, in part because of the economies of scale. For other reasons as well, they get capital much more cheaply, or as I once told someone during the discussions of healthcare reform, when we were talking about providing Medicare as a full market-priced option for anybody anywhere in the United States, and they said to me, "You really want to compete with Prudential, don't you?" And I said, "Well, kill them. We have such an enormous advantage on overhead costs." And the person looked at me a little quizzically and said, "Let's just start with executive compensation," where the person who is responsible for the Medicare program, and 38 million beneficiaries, is now paid about 1% of the CEO of Aetna, U.S. Healthcare, who has about 25 million enrollees, and which is losing money in the process. Medicare is making money at the moment. The interesting thing about the growing amount of discussion, to me, the interesting thing about the growing amount of discussion about using the individual health insurance market or recreating the individual health insurance market as a way to solve the problems of the growing number of uninsured people in the United States is that, in fact, individual health insurance, individually purchased health insurance, individual policies as a share of the total health insurance market over in this country over the last decade have been shrinking. And they've been shrinking rather dramatically to the point where now only about 5 or 6% of the population has individual insurance. I can't speak about what's happening in markets all over the United States, but I can tell you that what happened in New York and several of the other states in the Northeast, particularly around the time of the AIDS epidemic, was that folks began purchasing substantially more individual health insurance when they developed significant health care needs or significant expected health care expenses. And the risk pool that had always prevailed in the individual insurance market in New York, which had in fact been subsidized historically by the group health insurance market in New York, went to hell in an enormous hurry. Premiums went up very quickly, driving out everybody except the relatively ill until you got into what's called the death spiral of risk selection in the insurance market. Now, it is true that in order to continue to make individual insurance available in New York State, the political system intervened in a way advocates of markets don't care for, and essentially prevented the insurers from fully reflecting the relative risk of enrollees in the premiums, which transferred much of the loss associated with that kind of risk selection to the insurers from individual insurers, and then had to go through the back door to create all kinds of other subsidies of one sort or another. But even in a community-rated individual insurance market like that which we now have in New York, health insurance is expensive. If you remember back to what group insurance costs, we are talking as a national average for an average health insurance policy these days, an individual policy for an individual of average risk of between $3,500 and $4,000 a year, and we're talking about a family policy of $6,000 to $8,000 a year, and we're talking about communities in which median incomes of individuals probably are in the range of $25,000 to $30,000 before taxes. Now, there is a very important argument to be made on behalf of tax subsidies for individual health insurance, and I would be remiss if I didn't mention that, and that is the fact that all of us who have employer-based health insurance are essentially benefiting from a tax subsidy at the moment, in that our employers are able to treat those insurance costs as a deductible expense, and we are not taxed on the value of that insurance benefit. And it's been argued that it's very inequitable for individuals who don't get employer health insurance and have to pay for it themselves to be taxed on the income they have to use for that, while those of us who get it through our employers are not taxed, and I think that's entirely true. And I think it would be much fairer to extend the tax credit to everyone. I think it would be not only fair and more rational to eliminate the tax subsidy for everyone, but that's not something that one talks about in polite circles, at least not in Washington. But even if we do, the extent to which that is going to provide for increased health insurance for folks is highly questionable. Again, go back to thinking about the sort of vegetable metaphor a little bit. We have 150 million Americans today who are getting health insurance through an employer-provided benefit of one sort or another. And we have 42, 43, 45 million Americans who have no health insurance whatsoever. And if our agenda is not to maintain the status quo, but to move that 42 or 45 million number to zero, then if we're going to move away from the employer-based health insurance, we've got a total of 200 million people out of a population of 280 million that we have to worry about. And most of the alternatives that are being suggested as a way of doing that involve a whole set of concepts and ideas that work very beautifully in theoretical models of one sort or another, but are either largely untested in empirical examples or have been tested and found wanting over the years, to which their advocates always reply, well, that's because the experiment wasn't done entirely correctly. It is clear that there are a number of folks who are currently uninsured and not covered by public programs for whom the private health insurance market, whether on a group basis or on an individually subsidized basis, is never effectively going to work. And those includes people that includes people who are currently uninsured over the age of 50 or 55 who are just not attractive risks to any, and not receiving employment-based insurance, to any sane or awake health insurer. And it also includes folks who are not now covered by anything below about 200% of the poverty level, where the cost of decent insurance and insurance that's affordable to them, not only in terms of premiums, but in terms of what the coverage is and what they still have to pay out of pocket given the coverage, is just not realistic to expect them to absorb. And so it's very hard, if you sit down and start looking at this, to imagine getting to universal health insurance without expanding the public programs, the Medicaid program, upwards in terms not so much these days of eligibility limits, because under welfare reform and CHIP for moms and kids, the states can do whatever they want with eligibility limits, but for childless adults up to substantially closer to 200% of the poverty level. And I frankly think we're never going to get those now uninsured 55 to 64 insured without making Medicare available to them. But that still leaves you with half or more of the uninsured population. And frankly, then, the question is, if we're serious about getting them insured, to whom do you direct the subsidies?
The way I think of the uninsured is to divide them into three groups. First, there's the poor and the near poor, I'll say below 125% of the poverty line. Those people mostly don't have, people in that income group mostly don't have private health insurance, only about a third do. It's easy to say, it's easy for me to say because I have tenure, but the politicians really just ought to pay for health insurance for those people, I think. We can talk about ways of doing that, but the solution to that problem is to throw money at it, even in Arizona, to spend money to buy free or virtually free health insurance for low-income people, because that's the only way, and comprehensive health insurance, that's the only way you're going to get health insurance to them. At the other extreme, it's somewhat amazing if you think about it, 27% of the uninsured have incomes above 300% of the poverty line. That's the median income. There are a lot of, and some of them, I guess, are dot-com consultants who maybe lost their insurance, but there are an amazing number of people who are uninsured but definitely have incomes which, by anybody's definition, you'd think they could afford insurance, just choose not to do so. At the moment, I'm willing to let that group fend for itself, I guess. At some future date, we might want to do something about them. But I think the target group, the group that is of most concern and of most interest, and where the kind of tax credit approach that I favor may have the most effect, is this group of lower middle income workers between 125% and 300% of the poverty line. That's 40% of the uninsured. Almost half of the uninsured are in that group. And the interesting thing, an interesting characteristic of this group, is that although a lot of the uninsured are there, most people at that income level, actually by quite a large margin, do obtain employment-based group insurance. What I've tried to do in some recent work that will be appearing is to think of something real simple. And so my notion, I actually got this idea when I was working at home one day, and I went out and picked up the mail, and I got the value pack, which are these coupons. I don't know if you get them here, you must. So that proves you can get that the system is able to get coupons to people. that was sort of my one thought. And so my thought here is have a U.S. Treasury value pack, which contains in it coupons that say this coupon worth, for example, $1,500 off the premium for your next health insurance policy if you're an individual, and $3,500 off if you're a family, if you fall within this income level. And I can talk about how you could even target those people. If you're too rich, you're not allowed to use the coupon. We'll put you in jail if you do. But the idea would be that people then armed with these coupons would possibly do a lot of things. They might go to their employer currently not providing insurance and say, boss, I've got this coupon. It's only worth money if you can arrange health insurance for me to use it on, or at least that's the best way to arrange health insurance. Please, please take some money out of my wages, combine it with my coupon, and I'll be insured. Or if the boss is recalcitrant, or if the people are not employed in a large firm, they can go to their insurer and do it themselves. And I have a great belief in the greed of American capitalism to believe that the insurers will actually go out and find these people holding these coupons, because that's money for them. The big problem, as you may know, even as government has tried to expand Medicaid, is that about a third of the people who are eligible don't sign up, but that's because government hasn't employed the forces of greed. So that's what I'm imagining doing here. And I would, in contrast actually to the discriminating version, based on what I said a few minutes ago though, people could use this insurance on the credit on any real insurance of their choice. I wouldn't be picky about whether or not it covers podiatry. And finally, everybody at a given income level would be eligible for the credit, whether you got your insurance as an individual, whether you got it in some non-employment-based group like your church or the Moose Lodge or whatever, or whether you got it through your job, you would be allowed to use this credit. You'd either have to give up the value of the tax exclusion or net that out, but you'd still be allowed to use the credit. What this would do in the shining vision. Well, first of all, almost everybody would have some insurance. We've actually estimated, we think these lower middle income people would most likely buy what we call a $500,000 policy, a $500 deductible, $5,000 upper limit, but would cover a lot of the medical care which is important to their health. Second, their choice of job would not be distorted by the subsidized but inefficient small group insurance, and also their choice of coverage. I think the trade-off here is group insurance is cheaper than individual insurance. But to get group insurance, I have to let my boss pick my insurance. It's kind of like for your kids, you know, having them wear uniforms instead of getting things from the Abercrombie and Fitch or J. Crew catalog be a lot cheaper in terms of clothing budget per year. But what would be better? Well, different kids are different in that score, and we of course don't pay attention to their preferences. But for employees, the main virtue of the non-group individual market is that it allows people to have a great deal of choice. What I have in mind as a subsidy, though, is that the subsidy would be offered regardless of how people arrange their insurance. So if they are willing to give up some opportunities for choice and let the boss pick their insurance, they get the subsidy, or if they were willing to go the other way. High risks, I think, won't be a difficult problem. High-risk pool could pick them up. And then I even believe that, remember, for those people that I talked about at the beginning who are poor, initially I'd be willing to enroll them in Medicaid, but at some point I could even envision giving them a coupon worth 100% of the premium for a decent policy and giving them the same choice that the rest of us have.
We just released a study in Maryland. Uninsured use emergency rooms twice as much as the insured. Because they don't have preventive care, they don't have a family doctor to go to, and who pays for that? All of us. It's an economically stupid system. How else is it economically stupid? Based on something Bruce talked about. High amount of inefficiency where? Not in government. Here's another big myth. Government isn't the inefficient one. Private insurance companies. Private insurance companies spend about 12 to 15% on administration, including those high salaries Bruce talked about. Medicare, about 3%. Medicaid, or less than 3%. Let me just give you another way to look at those high salaries insurance companies make. The two top executives of United Healthcare in 1998 made about $40 million. If you made them live on $1 million each, you could have insured 20,000 Arizonians with that extra money, just off their salaries. So that's why we don't want to follow the siren song of tax credits and all the MSAs. One of the things you're doing is putting more money in their pockets. That's not what we want to do with our money. We at Maryland Citizens Health Initiative are looking at building a strong public system of health care for all. Now, we are not supporting a single-payer system. Many of us in Maryland believe single-payer is the most efficient and effective way of doing health care, everybody in one pool. However, at the state level, you just can't do it. And we also understand the polling that Bruce talked about, that most people who have private insurance like it and don't want to be moved off of it. But we also know that there are many people who are very unhappy with their private insurance. We conducted a poll in Maryland that 31% of Marylanders on private insurance have been denied medically necessary treatment by their insurance providers. So in addition to the problem of the uninsured, there's a serious problem in Maryland, and I'm sure here, with HMOs and other insurance companies not letting people have the quality health care they need. The president of the City Council of Baltimore, former president, her daughter was very ill, was on an HMO. The doctor said, bring her in this weekend for treatment. She went to the HMO. They said, nope, can't help you. Mary Pat Clark mortgaged her home. This kind of thing happens more and more and more. We need to create a system that can provide people quality health care in an efficient way without relying completely on the HMOs and the insurance companies. What we're doing in Maryland is we have brought some of the best minds in our state together from the Johns Hopkins School of Public Health, University of Maryland Law School, and Georgetown Medical Center to come up with a plan that makes sense for Maryland. We're going to have a publicly funded system, and we're going to allow people a choice between that and an employer system. How are we going to fund it? Well, one way we're going to fund it is to increase our tobacco tax some more. My hat's off to you, John Rivers, all of you, for your tobacco tax in Arizona, which is funding some of your health care, and is also reducing smoking. We raised our tax a couple years ago, reduced smoking by 16% in our state. We're going to raise it some more. And we're going to figure out other reasonable ways to raise the money to do this. We know that if we come up with a smart way of getting universal health care, the political will in Maryland, and I would say Arizona too, exists to do it. I've given you a document, our Declaration of Healthcare Independence. Over 1,100 organizations from all around the state have signed on to this document. They have come together to say, we're going to create a system of universal health care in our state. We're going to make it happen. What we're going to do is bring all these people together, come up with a smart plan. We're going to make it the #1 issue in the 2002 elections.
If you are, what your income is very strongly correlated with whether or not you have private health insurance. If you are making less than $20,000 a year, you have less than a 30% chance of having private health insurance, and a greater than 90% chance if you're making more than $60,000 a year. Next slide, please. And I'd like to, the Galen Institute logo is actually a conceptual chart that I'd like to use to describe my ideas. Next slide, please. If you are poor enough, this is for under age 65 population, if you are poor enough, you are very likely to qualify for publicly supported health insurance, most likely Medicaid. As you move up the income scale, you fall out of those public programs. It's not a sharp cliff because every state's rules are different. Before you begin to move into the higher paying jobs and the more stable jobs that are likely to provide health insurance. And most of the 42 million Americans that are uninsured are in this gap we call the Galen gap. They are making an average of $25,000 a year for a family, and they simply can't afford to buy their own health insurance coverage. Great many, I admire those who do, but a great majority of the 42 million who don't have health insurance are in this gap. And next slide, please. The way we have been talking about filling this gap over the last 10 years, maybe longer, has been talking about how we put more and more government money into this gap. Do we want to expand Medicaid? Do we want to expand Medicare down to people making at age 55? Creating the S-CHIP program to provide health insurance for kids, primarily in most states through the Medicaid program. But we want to talk about the other side. How do we begin to get some of the tax equity back to the people who are shut out of the system so that they can have private health insurance and not be on a public program that so often forces them to go to emergency rooms and makes it very difficult for them to see private doctors. The core of our idea really is looking at reforming the tax system so that you leave the system in place for 160 million people, but create something new for 42 million people who are shut out of the system, who aren't going to qualify, many of them don't want to be on public programs, but want to have some option to get health insurance. I have several other slides, which just maybe go quickly through them. I think we've run out of time. Most of these points have already been made, that subsidies would be targeted directly to individuals, therefore the insurance would be portable, they wouldn't lose it when they lose and move from job to job, and it would be, next slide please, targeted specifically to the uninsured. And it is a double win because it's a tax cut for them. It essentially says if you owe $3,000 in taxes, instead of sending that $3,000 to Washington, you're going to get, under the Bush plan, but it probably will be raised, $2,000 you can hold on to $2,000 as long as you spend that money on health insurance. And then you send the other $1,000 to Washington. But it gives you an actual real money, and we can talk about all the ways that can be distributed so they have the money as real premiums. But it helps people to have the money that they don't now to purchase their own health insurance. The tax credit would work much like the mortgage interest deduction. If you take a mortgage interest deduction and you didn't actually pay that much money and for your mortgage, then you've committed fraud. So you really want to work on an incentive basis. Give people the money, encourage them to spend it on health insurance, and then there will have to be penalties if they don't spend it on what the law says that they have to. So, but I don't think you want to start out with a mandate for health insurance, because it's not going to work to have an individual mandate even more than it works to try an employer mandate, which we discussed during the Clinton years. But if you put, as Mark has said, if you put the carrot out there, give people an incentive to buy health insurance, his research shows that if you provide a tax credit that's worth half the value of a decent policy, then half of the uninsured will become insured. Then let's have the conversation about the rest of that population and find out what do we need to do to reach them as well.
Bruce, does that work from your perspective? Thank you. Sure. Well, I always find it amusing when conservatives seek to contrast the intrusive bureaucracy of government insurance programs with the automatic mechanisms of working things through the Internal Revenue Service. As so much more benign and desirable. I just think it's important to clarify for the record that the difference between spending $2,000 by giving somebody a tax credit or a voucher and spending $2,000 by paying part of the cost of, say, a child health insurance program for them is almost purely a semantic difference. It's the same $2,000 of the taxpayers' money or the government's money, which is the same money, whatever you call it.
People will find new ways to pool themselves. I think instead of just having the employment-based pool as their only option to get health insurance, that labor unions, professional associations, churches may very well say, we think that we're more likely to be able to serve our members if we organize health insurance for them. So while we talk about an individual market, it simply would be just give people more options of where they purchase health insurance and how that's organized rather than just through the employer. And as a result of having that insurance be catering more directly to consumers rather than to company HR directors or politicians and bureaucrats in Washington, you would have much more consumer direction on what are the shape of those policies and are they offering something that people want to buy. If there's a competitive market, then they're going to have to offer something that people want to buy or they're going to go someplace else. And finally, the last slide I didn't get to, whoever controls the money controls the choices. Right now, if you have health insurance through a government program, it's directed by politicians and their agents in the bureaucracy. If you have job-based health insurance, the shape of the policy is directed by the HR department and the management of the company. If you had an individual tax credit so that people are able to purchase their own health insurance, they control the choices. And I think that's the real difference in the approaches.
What people want choice in is not which HMO they have. They want a choice of doctors. They want a choice of providers. What tax credits are is a way of putting more money in the hands of the insurance companies and the HMOs who have plenty of our money already. What we need is a public system that people pay into in a fair, progressive way, and then they get a freedom of choice of doctors, freedom of choice of hospitals. That's what people want freedom of choice of. They don't want to be thrown to the wolves of the HMOs and the Aetnas anymore. So I think we ought to reject completely the tax credits and MSA approach and come up with a sound public approach funded by progressive taxes, tobacco taxes, which will get us quality health care for all in the same way.
I said, I think this issue of what about the high-risk uninsured is largely a red herring, a false problem. For one thing, the great bulk of the uninsured are not high risk. In fact, the modal uninsured person is Fonzie, 26 years old, working part-time down at the motorcycle shop, in terrific shape, doesn't think he needs health insurance. That's the person you have to worry about. For another thing, as I said in my remarks, guaranteed renewability means if you buy insurance like you should, and this is what my father's advice was for me on almost everything, you should have thought of that beforehand. We want people to sign up for insurance when they're healthy. If there's guaranteed renewability, then they're absolutely protected when they're sick. Now, of course, this is a big country and sad things happen, and there are people who chose not to be without health insurance when they were healthy and then get sick and wonder why can't I call from my cell phone in the ambulance and see if I can sign up for some health insurance. But I think, not to be nasty, but anybody knows you can't run a private insurance system that way. You need, one way or another, either whether it's the carrot or the stick, you need to get people to be insured when they're healthy, and then when they become unhealthy, they'll be able to retain that insurance. Now, I wouldn't say it's easy, and it's not going to be perfect. There'll still be a few people fall through the cracks. And then the main issue is whether you think that's a price you're willing to pay to allow people to make their own choices about what kind of insurance they want and how much they're willing to trade off additional benefits against higher premiums and so forth.
Bruce? I'm a little baffled by this conversation because I think the notion of substantially expanding coverage in an economically efficient way by expanding the individual market, is inconsistent with the empirical history of the individual insurance market, with which I'm familiar, and B, assumes that the great majority of those writing health insurance are both stupid and honest, which is not my experience with the insurance industry. Now, I understand what Mark said about the theoretical literature and so on and so forth, but I happen to have been an employer of an organization in New York City during the height of the AIDS epidemic, and I can tell you the notion that group health insurance doesn't effectively pool risk isn't true. And I can tell you that in fact, the amount of compensation available for employees, wages plus fringes, is not a fixed amount. It is a trade-off made either in a minority of American workplaces through collective bargaining, or it is a trade-off made by corporate managers in terms of short-term profitability versus investment in the workforce, which varies very substantially over time as a function of the nature of the labor market. And the fact of the matter is that if people with significant health histories who are not now uninsured are going to get health insurance in a private insurance market, and if insurers are not all honest and dumb, you're going to need some very significant regulatory interventions in that market in order to make that insurance available to them, or you're going to need to require a level of cross-subsidy in that insurance market that is so complicated that that's a large part of what killed the Clinton health reform proposal. So, I mean, it is, if you're in the private health insurance business, the only way you can ensure that you'll remain in business is by not insuring sick people. And there are lots of ways insurers know how to do that. And if you prevent them from employing those ways, and they're not more clever than you are, and still figure out how not to do it. I think we are at a period in the healthcare system, and I think it's interesting to see the way that so many of the sort of policy discussions have sought to deal with this by changing the subject, in which, having long acknowledged all the inherently inadequate and inefficient characteristics of the, quote, traditional highly fragmented fee-for-service system, which has less to do, in my view, with the way in which providers are paid than with the absence of any organized sort of standard setting or oversight about standards of practice. We are now rejecting the crude bureaucratization of standards as it's been carried out in much of the managed care world. And so my friend and former boss, Jack Rowe, is taking over Aetna and running around making all these noises about a new paradigm that's going to do away with all the evils of managed care and still provide people cost-effective private health insurance. And it's wonderful rhetoric. He has no idea what he's going to do because nobody knows how to do it. And we have real problems that are just beginning to be made explicit that the managed care experience has taught us, but I think have much broader implications about what does an insurance benefit mean? What does an insurance contract mean? Who gets to determine what's a covered service and what isn't? If medical necessity is your criterion for coverage, what does that mean and who gets to decide? A lot of the debate still going on around this subject, I think, is at the level of finger-pointing and rhetoric, and it's been attenuated over the last few years because everybody's been feeling so prosperous that they've been able to sort of cover over a lot of these problems. But the fact is that a large part of the health insurance market has rejected management of care without having rejected some of the underlying arguments for why you do need to manage care. And when the market gets tighter, as it's going to begin to do, these issues are going to resurface with a vengeance, and we just as a society, as a government, and most of our communities have no concept how to deal with these issues, and the Patient's Bill of Rights doesn't really address them very effectively at all. I mean, my personal argument on this subject, one more minute, has been with some folks in Washington. I have at least one United States Senator who no longer speaks to me at all because I hurt his feelings when I told him he didn't know what a defined benefit was. And that, in fact, the Federal Employees Health Benefits Program is not a defined benefit program the way Medicare is a defined benefit program. And that's because the real hard issues in health insurance are who gets to decide at the end of the day whether you're going to pay a claim or not pay a claim. And in neither of the public or private sectors are we having a very thoughtful conversation about what that really means.
I think that the state children's health insurance program is something that easily could be turned into a kind of a tax credit or voucher so that parents could include their children in their health plan. The tax credit idea is really, it's like a concentric circle. If you start out with a tax credit for individuals, then they can begin to reshape the market to cater to what kinds of policies they want to purchase. States can put additional money on for high-risk individuals. The state children's health insurance funds, which are already out there, could be used to add children to parents' policies so they don't have to be on Medicaid-like programs as they are in many states. And I also think the tax credits are a much more viable option for people who are much more vulnerable, age 55 to 65, that want to purchase health insurance. They no longer have the option of employment-based health insurance. So I actually think that tax credits are much more appropriate for the most vulnerable people, and I suspect that that's who Congress is actually going to target them to as well.
Tax credits is being pushed by wealthy and the insurance companies. And the only reason, can I finish? So they're part of this, the Strange Bedfellows Alliance that's looking at that.
Not tax credits for
The point is, the only reason tax credits are on the agenda is because they stopped the vote count in Florida. But the fact of the matter is,
Vice President Gore had a tax credit.
The fact of the matter is that what we need to do is come up with a plan that deals with the broad range of problems in our health insurance system. And the doctor over there pointed out that managed care, HMOs are creating serious problems for people with insurance. And if all you do is tax credits that puts more money in the hands of the HMOs, you are not dealing with those problems, you are making them worse. We need to come up with a public system, fairly, progressively funded, to provide comprehensive benefits for adults and children. And let me quickly talk about my fellow Italian Fonzie. We believe healthcare is not only a right but a responsibility. People should all be putting into the system so that we're all covered when we need to be.
One of the reasons that states like Arizona, Texas, New Mexico have such high uninsured rates is because they have a disproportionate number of people in the Galen Gap. And especially Hispanic populations are off the charts likely to be uninsured for a lot of the same reasons: lower income, a lot of mobility between jobs. A tax credit that goes directly to the individual, or call it a voucher, whatever you want to say, money from the federal government to say, we want to encourage you to purchase health insurance. You can have that delivered in a number of different ways. People can have lower the amount of withholding from their paycheck, so their checks are bigger every month so that they can provide, have more money to pay the health insurance premiums. If a parent is eligible if a child is eligible for a tax credit through S-CHIP, the parent can essentially say, I want to get that money on a month-to-month basis to pay the higher premium. They could get it at the end of the year. It could be allocated through some federal mechanism directly to the state, to the health insurance company. There are a lot of different ways that the money can be delivered. The crucial thing is to figure out how to get something to people in that gap so they have much of the same chance that people on either end of that spectrum do. And I think Arizonans would be particularly advantaged by this kind of idea.
Yeah, two issues relative to Arizona. I think it's entirely right that the kind of tax credit, the level Mark talked about, would be relatively more valuable in Arizona and Texas than in New York, where it would be entirely worthless for most of our uninsured, because the fraction of a health insurance premium they would pay is not enough to let people afford the balance of that. Yeah, you can always buy something for any amount of money, and the question is whether I want to use my taxpayers' dollars to buy some of the dreck that passes for health insurance in the United States, or whether it'd be more efficient just to have a big bonfire in front of the Capitol and burn all the money up that way. And you probably have air pollution problems there, but the distribution costs would be less. The other thing to say, though, that is a coming issue here, because the uninsured are a dynamic population, not a static population, that I suspect is a big problem in Arizona. I know it's a big problem in California. I know it's a big problem in New York. The growing proportion of the uninsured in that Galen Gap who are legal immigrants to this country but have arrived since 1996. And unless we're prepared to treat eligibility for a private tax credit different from eligibility for Medicaid, we are going to miss a very large and growing proportion of all the uninsured in any kinds of subsidy. And if we are then going to say that if you are a legal immigrant who arrived in this country after July of 1996, you can get a tax credit, but if you're poor, you can't get Medicaid, I think that's going to create some real cognitive dissonance. For those of us outside the Beltway, people in the Beltway will do that happily without bothering them at all. But we have to understand, I think, in Arizona, in Texas, in California, in New York, and a minority of other states, but which may numerically have a majority of the total uninsured population in the United States, the extent to which, in New York City, 40% of the uninsured adults are immigrants. Of course, half the population of New York City is foreign-born, so that's not unrepresentative. But increasingly, the relationship between the problem of the uninsured and the problems of immigration, and again, especially of legal immigrants who arrived in this country after the enactment of welfare reform.
The primary problem with health insurance in the United States isn't that it's expensive for high risks, it's that it's expensive for everybody. And so a solution to that, at least for people who cannot afford that expense, is exactly the idea of a tax credit, to make it affordable. The issue of cost containment and whether the increases in insurance premiums that people are seeing reflect benefits or not is much more debatable, I think. But at the moment, at least for most employers, we're seeing them willing to pay that extra premium, have their employees pay that extra premium. I need to be true to myself, because it's worth it. Sure, you could have I could sell you, or an insurance company could sell you an insurance policy that would be cheap. It would pay the 1980s benefits for 1980s technology, doctor, and I don't think that many people would choose that.
If Congress were to approve $40 billion for tax credits for individuals to purchase private health insurance, the market would change. You know, you're going to find policies, once again, whoever controls the money controls the choices. They're going to have you're going to have competing policies. You're going to have many of the same kinds of forces that operate in other sectors of the economy are suddenly going to start operating in the health insurance and the health sector where they don't now, because decisions are made through collectivist kinds of decisions rather than based upon how do we make that individual consumer eligible and want to buy our health insurance policy. And in an information era in which people have so much information available through the internet, it's going to enable people to get information in a way that is accessible to them, and the companies that are selling that insurance are going to have to make it accessible in order to show employees to show individuals how their product competes. We see it all the time through the Federal Employee Health Benefit Plan that covers 9 million federal workers, retirees, and dependents, in which plans compete against each other for the business of those employees. And it's a wonderful system that could, in fact, become the model for this individual tax credit.
1 minute response, and then we're going to wrap it up for a break. Minnie.
As Bruce mentioned earlier, tax credits mostly benefit the wealthy. It's just another way of putting more money in the hands of the wealthy is what it's all about. And I agree with what the woman just said before, that you can't expect people to be choosing between insurance plans. You got to want people to choose which doctor they want to go to. That's what we want, the kind of choice we want. Let's take that $40 billion instead and expand Medicare. I heard one doctor in Maryland say he's got a 3-word amendment for Medicare: delete over 65. What we need to do is create a system in this country where everybody has access to quality, affordable health care, everybody has freedom of choice of doctors, and we're not going to get it in the federal government these days, but let's do it state by state. We're going to do it in Maryland, and we hope Arizona can do the same, and one way to do it is bring that tobacco tax up again.
Tax credits do not benefit the wealthy. The design of tax credits, as proposed by Senator Bradley, Vice President Gore, and Governor Bush, all provide very generous tax credits to low-income people and phase them out for high-income people. I don't deserve a tax credit. My administrative assistant does. Insurance is complicated. There's no way to get around that. On the other hand, most people say the two problems with insurance are people don't know what they're doing, and they're able to engage in adverse selection in which they decide which insurance is most advantageous for them and go and buy it. I would point out to you those two comments are logically inconsistent. If you're smart enough to figure out the insurance that will benefit you, you figured out something about insurance. But I think, as I said a few minutes ago, the ultimate solution is to make available to people a government-run insurance policy. That's the destination for people who think they don't know what's a good insurance policy for them, and they'd rather trust an elected official to choose their policy rather than they themselves. I'm willing to let people do whatever they want.
Last word, Bruce.
A couple of factual things very quickly, and then just a concluding sort of comment. The notion that, well, no real health insurance market that's ever existed has behaved the way the market's supposed to behave with expanded tax credits for insurance, the market will respond to that, is a logical equivalent of what I used to call the premium support fairy, the magic of the market is going to make it work. Well, in fact, the reason we have health insurance in the first place is because the pervasive, systematic, and unavoidable characteristics of market failure in the market for healthcare services. And you need a hell of a regulatory scheme to overcome them, and at some point, that regulatory scheme becomes self-defeating. Second, I'm sort of tired of the bad-mouthing about Medicaid. The fact of the matter is there are a lot of things wrong with the Medicaid program, but if you look at the actual data on access to and use of health care by Medicaid, controlling for the characteristics of beneficiaries, including their disproportionate status in ethnic minority groups, they look a hell of a lot more like people with private health insurance than they look like uninsured people. In fact, at the 75 cents on the dollar states have been paying to support the Medicaid program, it really is a remarkably efficient form of health insurance in a variety of ways as well, including access to so-called, quote, mainstream providers. In most parts of the country where historical patterns of racial and ethnic discrimination don't continue to dominate who gets their care where. Finally, the last thing I would say is that one of the things that characterizes civilized societies from tribal hunters and gatherers is the notion of agency or representation. That in modern societies we don't have to do everything for ourselves. We could give everybody a quiz on how the electronic fuel injection in their car works, which is something they encounter on a more regular basis in the healthcare system. And not only do we not know, we don't want to know, and we don't want to have to know. We pay people to know for us, and to healthcare is an area in which people particularly desire not to have to know. Those who want to know are welcome to go to the internet and so forth, and the rest of us can go to doctors. And you can do all sorts of quizzes to show what people do know and don't know about health insurance, but the notion that people will be better off because they have to study health insurance is similar to the notion that to me says individual choice is better than choice by politicians. And I don't like all our politicians, and I'm very worried about the state of the political system. But somewhere at core here is a notion of the fundamental concept of being citizens of a representative democracy. And if you believe that that's not a legitimate way to make decisions about real important issues, then we've got a worse problem. And if you believe it is a valid way to make decisions about real important issues, but our system is so broken now that it's not working, then we have a separate set of agendas. But if in a truly effective representative democracy, the people say, we can't afford market failure in health care because it leaves too many people who are hurting uncared for, we are going to have to collectively, as a society, do something about it. Then you're talking about having your elected officials decide what kind of health insurance you're going to get. And either you don't believe in democracy or you don't believe our democracy is working right, in which case we need to fix our democracy in order to fix our health care system. And that's what this issue is really about.
We don't have health care in America. We have a sick care system. And until we develop a new paradigm for health care, many of the good ideas on the table will never do anything to, one, bring down the cost, and secondly, and most importantly, provide more coverage for everybody. And thirdly, no mandates.
When looking at civil rights and comparing the progress made there with universal health coverage, Martin Luther King was an optimist. In 1969, when I got my MPH from Berkeley, everyone was predicting that universal health coverage was just around the corner. How long? Not long. Well, maybe not, maybe kind of pretty long. Because even today, as we have this debate, we don't see persons at the highest level of government sharing a vision at all that speaks to the fact that healthcare ought to be a right rather than a privilege. And I'd like to just share a little bit about from a consumer perspective, because I do work for an organization that is consumer driven. But I also want to say that I did some important consumer research that ended about 10 hours ago as I was coming in from the airport, because a wonderful taxi driver picked me up to protect his identity. His name could have been Omar. He may have been from the Middle East, or Jorge. He could have been from Mexico, or Willie Joe from the trailer park, or recently from Arkansas, or John Henry from the hood. I'm not going to tell you his name. I want to protect his identity. But he was very honest with me when I told him I was coming to this conference today and I was going to speak to you about this particular subject. This taxi driver works 12 to 16 hours each and every day. The first 8 hours that he works, he's paying for the cab and for the gas that he has to use in order to drive his customers around. The remainder of the time, the other 4 to 8 hours, he's earning money for his family to pursue his pursuit of happiness. But he is an independent operator. His wife also works, who works part-time. They have 2 children, 9 and 6, and they are citizens of this country and they are taxpayers. But he has no health insurance, and neither does his wife. His children are not covered, and he doesn't know about kids' care in Arizona. His primary way of dealing with health coverage for his family is to pray that nobody gets sick. And he tells his children to be careful when they play. When I asked him why he doesn't have health insurance, he says he cannot afford it. He says just making it and working his job and a half, and his wife working half-time because they don't want their children to be latchkey children, just does not leave enough money to pay for health insurance. But I told him that he was going to be my consultant, and could he tell me a few things to tell you this morning? And so this is really fresh stuff. I said, what would you like? He said, you know what I'd like is just some plain vanilla health coverage. Nothing fancy, nothing in a fancy wrapper, just plain vanilla health care. I'd like to, even if I just had generic drugs, I don't need brand names, just give me generic drugs. He says, I just need enough coverage so that my family's finances will not be wrecked in the event that somebody gets sick. Then I asked him, what about your colleagues? Are they covered? He said, I'm sorry to tell you, they aren't covered either. And I could hear Martin King's voice again. How long? Not long, because we reap what we sow. You see, when I asked the cab driver or I remarked to him, you know, he's kind of vulnerable in this little closed-up taxi cab because if I started coughing, I could contaminate the air that he was breathing, and then he might get sick, and then anybody else that got in the cab after him might also get sick. And he said, you know, you're right about that, since visitors from all over the world come from the airport. But he says, if I get sick, I just get sick. I don't have any choices. Well, it turns out that when we look at our cab driver, he represents an interesting segment of the people that we have been talking about in part, because there are some groups that are at greater risk for being uninsured. If you are Latino, you're more vulnerable not to have health coverage. If you are a woman, you're more vulnerable not to have health coverage. If you are an adult, if you're an African American, if you are a person with only a high school education, there's a higher probability that you will not be covered for health insurance. Is employer health insurance obsolete? I think the question ought to be, is employer-based health insurance enough? And the fact of the matter is that it's not. And that I would suggest to you that while we debate trying to come up with a perfect solution, we ought to be doing some things to deal with our cab driver. We ought to be tweaking, if you will, the system and trying a little bit here and a little bit there, but not giving up on the pursuit that we ought to make it a right and not just a privilege. I don't think any one solution will work, and I'm also afraid that anybody that talks about a revolution, overturning everything, perhaps is not concerned about our friend, the taxi cab driver, because by the time that happens, he will be an old man too. My cab driver understood. He's willing to contribute if the price is right. His challenge is really us. the special interest groups that we all represent. His challenge is that we demand that we must make certain that our service, our interest is covered, that we demand that there must be mandates so everything is covered. And that's wonderful, except that our cab driver will never afford what it is that we demand.
Let me start with point number one, because in the end, none of this is very funny. First item is what I call Jurassic Park. And it's a confession, it's an acknowledgement, and it has to be put on the table because I'm supposed to give you the provider's perspective. To some extent, it's going to be in part a self-serving perspective, but it is the provider's perspective. We really screwed up in the 60s and the 70s and the 80s. We were inefficient, we feared accountability, we were not responsible, and boy did we know how to finesse certificate of need and rate review. And any time we got in trouble, we just raised the frickin' rates. And any time we wanted to get a CON, boy, we just stacked the deck and scared the crap out of the housewives who were sitting on the other side of the table. And we got everything we wanted. And we did, in fact, engage in an arms race. And we did, in fact, overbed communities across America. We really, really screwed up. And to some extent, we deserve what we got. But that is Jurassic Park, that is history that no longer is relevant, it doesn't count in the debate. And I grow weary of hearing what we did years ago that has no relevance or application to the future. So that's the confession, that's Jurassic Park. Point number two. I am not going to be particularly restrained in my comments, and some of you are not going to like them. But to some extent, I've grown so weary of the rhetoric, I really don't care. If there are evaluation forms and you want to put them all on the left or right, I don't care either. But I was asked by Roger to give the provider's perspective, and I'm going to. So here we go. This is point number three. I want to offer congratulations to the following. I want to offer major congratulations to the drug companies. 4 relatively small drug companies last year made $20 billion in profits. And they're selling to us directly just in case we're sneezing or we need a little boost on our sexual lives. Actually, I suppose if you take the drug, it'll be a big boost, but medical surgical suppliers, congratulations to them. They're buying companies left and right with the profits made from healthcare. Good for them. Let me congratulate certain insurers and brokers, which and who over time have made big bucks and have somehow persuaded the American public that they're providers. Somehow we have become convinced, some of us, that managed care entities are actually providers of care. Congratulations. Very slick. Congratulations to Maricopa County. Maricopa County collects taxes, my taxes and your taxes. It's supposed to take care of the indigent. The indigent show up in my emergency department and I get reimbursed 11 cents on the dollar. That stinks. But congratulations to Maricopa County. Well done. Congratulations to some of our vendors who demand that we pay quickly and totally, and whose employees come to our emergency department and don't pay us for the care provided. Very smooth. Congratulations to those people who keep bad-mouthing mandates and do nothing about EMTALA, the Emergency Medical Treatment and Active Labor Act, which effectively is universal coverage in America. And nobody gets it. Roger, you wanted the provider perspective. This is the provider perspective. You come into the emergency department and you are given care by law and you don't have to pay us. Congratulations to those people who have identified which organs of the body are profitable. Apparently, the heart organ is profitable. Bones are profitable. Those organs of the body diseased by chronic illnesses are not. So congratulations to those cherry pickers. Congratulations to the lobbyists who block reform and change. Congratulations to the PR firms who come up with one or two word phrases that absolutely kill reformation. You want to kill reform? Socialized medicine. That's socialized medicine. So's Medicare. Medicare is socialized medicine. You don't like socialized medicine? Go to your parents, get their Medicare cards, and destroy them. Thank you, Vinny. Point number 5. These will stitch together, I hope. Those people who bad-mouthed an attempt at reformation years ago said the following would happen if we passed the then-known Clinton plan. This is what was going to happen if we went ahead with the Clinton plan. Hillary Care. Any small thing to kind of bust that effort apart, notwithstanding the fact that the White House was arrogant and secretive in its approach. This is what they said. If you pass that sucker, we're going to have more uninsured. Nurses and doctors are going to begin to leave if we have this. We're going to commit more medical errors. We're going to start diverting people away from our emergency departments. The only thing I can come up with is that colloquial expression that goes something like this. Duh. Just duh. That was what was going to happen. We'll let the unfettered marketplace work. Now you tell me, an unfettered marketplace, what is the economic incentive in an unfettered marketplace? To provide service or products to people that you know can't pay you? I want the house. Cool. I like the caddy. It's yours, but I can't pay. Doesn't make any difference. And when you hear about some of the activities of those that I congratulated earlier, you begin to wonder, remember, some of this was our fault. We really screwed up. But that was Jurassic Park. So what do we do? And this, by the way, for any of you keeping notes, is point number 6. Here are the potential alternatives as I see them. Pray. But of course, we've done that today. Another alternative is called yakety yak. Keep having these conferences with no conclusion. Well, I think this and I think that. That's very nice. Have we heard this before? Yeah, maybe not as eloquently as we've heard today. But that's an alternative. Alternative is yakety yak. Another is do nothing. And after all, there was not a single person who put up his or her hand that you represent the uninsured. What the heck do you care? Oh, how about raging incrementalism? Certainly the pharmaceutical companies are not engorged enough. Let's take some tax money, billions, to provide a prescription drug benefit because those people aren't making enough money over there who supply the drugs. And meanwhile, Arizonans will go across the border to Mexico to get pharmaceuticals. It continues to befuddle me that one of the structural answers is right here in Arizona. And we don't, I mean, it's kind of, the expression again is in a colloquialism. It blows my mind that we don't know it's right here, and it's the Access Program, which is the Alan Enthoven version of managed competition, which allows the best of capitalism under a managed environment, so you're not playing games, to take care of a ton of people with a basic defined benefit package that's 13% less expensive than anything else in the country like it, and gets quality marks that are better than anything else like it in the country. It just blows my mind. It's right here, called the Arizona Healthcare Cost Containment System. We, as providers, bid for the privilege of taking care of people, They can enroll and go to any other plan if they don't like waiting times or doctors. They can, every 12 months, the whole bunch of them gets out, and they can choose based on who they really like. Did the doctor keep them waiting? Was the doctor do good? Did I get well? It's preventive-oriented, and there's an incentive to stay away from the provider to some extent, but somebody's checking to make sure we're not responsible for underutilization. Well, it had 500,000 Arizonans that are kind of pure Medicaid. Now, thankfully, the people of Arizona, and by the way, they keep speaking. It's kind of amazing that Arizona people keep saying the same thing. We want the uninsured to be covered. And by the way, we'll pass Proposition 203. Nothing happens. Okay, up yours, we'll do 204. And if you keep it up, it'll be 205. But we got the waiver, so now 380,000, if I have the number right, 380,000 additional people are eligible. The law was written also to provide that same structure to state employees. The largest employer in the state of Arizona is the state of Arizona. Now you begin to add all that up. That's a managed competition model that works. And by the way, providers bid, so do insurance companies. Cigna's in this. Blue Cross had been. Samaritan, which became Banner, which became Neon or whatever, was in it before it sold to United. Vanguard will be in it. It works, and if it works for people now between 35% and 100% of poverty and could work for state employees, then why not for others? And let us all kind of get in there and bid and stop wasting the money that never seems to get to the care site.
I think we have to do several things simultaneously. One, we have to make certain that we don't get caught up in sweeping generalizations. There are some messes, but not everything's a mess. The system works for those that are in the system. It's just not working for those outside of the system. So we have to make certain that we're not throwing everything out in order to make it work for everybody. So I would say the following. Number one, we have to have a serious conversation in our society about where healthcare does stand. And to get to this issue about right versus privilege. We've never had a mature conversation about that. However we conclude that will lead to ultimately what solutions we put in place. But we have to have that conversation and not nibble around the edges on it. Number two, with respect to that which is working, then we ought to not mess with that as much as to address what isn't working. And as much as I hate to compromise on issues of total solutions, but raging incrementalism helps a lot of people. And I think that while we're waiting for the perfect to happen, we have to find ways of improving and extending access in Arizona or Medicaid, as we know it in other states. We have to look at Medicare, look at the other programs, and just continue to bring more people into coverage, but not say, let's wait until we can cover all 42 million at one time before we do something. But it is important, I believe, that we have this mature conversation about what kind of social contract do we have as a society. The other nations that have universal coverage have decided that that's part of their social fabric. To be a citizen of their country means that, among other things, you have health care as a right. I think we need to have that conversation. You're absolutely correct. It's not a one-way trip on this. The patient, citizens also have responsibility, not only in terms of deciding what particular system to participate in, but also our behavior, and whether we're talking about issues around smoking or inappropriately eating or lack of exercise or the other kinds of things that impact our health status. We clearly, as healthcare practitioners, providers, physicians, also have to participate more in the education of our consumers, our patients, so that they will own their behavior also. It's all in there together, but there is no magic, no single way to make this all happen.
If you run a real reality check, I noticed a number of people who are, quote, providers, nurses, doctors, et cetera, who raised their hands. But for those of you who want a real good reality check, I can help arrange this if you'd like. is to spend a 24-hour, 12-hour, whatever you'd like, period of time in the ER. Just kind of look at humanity. And when I hear things like they come to us because they're looking for food, they come to my system, emergency facilities, looking for food and clothing and housing. And it is the ultimate safety net, and it's being shredded. That's not crybaby stuff, that is reality. So as we sit here on these wonderful, the Camelback Inn, for crying out loud, and we're making all these really nifty kind of comments, if you want to know how it's going on, go to the emergency department or talk to a nurse. And by the way, the nurse is probably the most respected, most trusted individual in healthcare today, so don't talk to the docs or to guys like me, talk to the nurses, who, by the way, are bailing.
I would answer it this way. The responsibility of the individual is individual responsibility. But some people are not going to get there without becoming more aware, more informed, and more educated about the risks that they take by not doing it. Let me give you a real simple example. I recall as a younger man in an earlier life when they had the Keep America Beautiful campaign, because people were throwing trash on the highways, on the byways, in the cities, et cetera, and on and on and on. And so I don't remember offhand which of the first ladies sponsored it. Some of you may remember it, you're as old as I am. Who was it? Lady Bird Johnson. She basically drove the idea of Keep America Beautiful with an awareness campaign, and after a while, our cities and our highways and our country wasn't as cluttered and as dirty because she appealed to people's sense of responsibility to be a part of the solution rather than a part of the problem.